So during today's webinar, we'll cover a variety of topics with Jeri Ann, focused first on COVID-19 and how it's impacting the Decatur lung screening program and how they've been re-engaging with customers. She'll also talk about her technology stack and the different solutions that they have been using to track their patients and manage keeping patients on track in an efficient way. And last, she'll also share a little bit about how they've been modifying some of their software or using their software in new ways to track COVID-specific information within the confines of the lung screening program. I'm going to turn it over to Jeri right now to introduce herself, tell us a little bit more about the Decatur Memorial Hospital lung screening program, and then Lauren Riley, an Aspen lung expert here at Volpara Health, will guide the discussion with Jeri, and we're so thankful for your time. So Jeri, if you could tell us a little bit about Decatur.
Yeah, good afternoon. Thanks for logging on today. We are, like the slide says, we're located right in the middle of Illinois, and we're a fully accredited and licensed 300-bed facility. And we are designated and accredited by the ACR in our lung cancer screening program for the low-dose CT. I started back with Decatur Memorial in 2003 as a film librarian, and of course that position doesn't really exist anymore, and I went on to be a tech assistant, then a licensed tech, and then in 2016 there was an opportunity for the lung navigator position. We actually consider my position an imaging navigator throughout for the department. The lung cancer screening program is my main hat that I wear, but there's a few other responsibilities that I cover, and then in a leadership role for some of the technologists that I work with and colleagues. And of course, the main goal of our program is to increase screenings and detect lung cancer early when it can be curable.
Great. Okay, so next slide, we're going to talk about Decatur Hospital's lung screening program. To begin, Jeri Ann, could you tell us a little bit about your local population and how you determine who's eligible?
Yeah, we're right in Decatur, Illinois, so right in the middle of Macon County, but we serve several counties around us. And from the demographics that we've pulled and showed and some of the statistics that we use from some of the collaboratives that we're in, we show that our population that we serve, about 8% are eligible for the screening, participate in the screening, which national average just went from 3.8 to 5 in the last couple months. So we're still, a little above national average, but again, that's still not much to brag about, considering that percentage is still a lot lower than what we would like to see it. And then as far as our program, we follow a couple of the different guidelines, and the requirements are 55 to 80. Medicare, however, only covers to 77, so we make those patients aware that fall in that 78, 79, 80 range. But we will continue to screen if they would like, but it might not be reimbursed by Medicare. And then we, of course, go with the standards of the either being a current smoker or have smoked in the last 15 years, and then the 30-pack history rule also.
Hey, and what is your referral base like?
We have my main referral base is my pulmonologist, our lung center. They are very strong believers in lung cancer screening, which is great. And then we have several specialists that are on board, a couple of my surgeons, general surgeons, some of my cardiologists, and then we have our primary care practices too that also refer in.
That's great. Okay, next slide. So now we're going to talk about some of the screening program volumes and goals. So Jeri Ann, I wanted to hear about how your program measures success.
Yeah, we have kind of set, like at the very beginning back in 2016, we like to see at least a 20% growth in our screenings every year. That's kind of like our gold standard to see if we reach for the year. We have done that in years prior. This year, I think we're going to be a little short, which is understandable, but still a little frustrating. However, yeah, this year we were on target for 1,250 screenings. We're going to have a really big December to reach that. So we'll see if we can get there or not. And then, yeah, our program currently tracks about 1,500 patients in total.
Okay. And what would you say differentiates you and your other screening programs?
From the different collaborations that we're in, that we participate with different organizations, where we kind of stand out a little bit differently is our radiologist base is really strong, which is awesome. We have a lead radiologist that really puts a lot of time and effort into our program, and several of the other radiologists do too. And they do it's called the Radiologist Consultation Services, and mainly for the lung cancer screening program, but we do use that in other areas. And that's same-day results in our radiology consultation area. We have big TV screens on the walls, and after the patients get done with their scans, we take them in there and do same-day results, and we do an image review, which not only does that help, a picture's worth 1,000 words kind of concept as far as showing them any abnormalities on their scans, but that also is where we do our smoking cessation piece. We show them signs of their emphysema and chronic bronchitis, and kind of makes it a little bit more real for them. And we do notice that they like to kind of, the next year, whenever they come back, this year's been a little disappointing because we have put that service on hold just to limit, the patients being in the building any longer than what they have to be. But we are still doing that via phone. But it's still, whenever we were able to do that in person, it was really nice, kind of an eye-opener for them to see that it wasn't just words on a paper. We were actually just showing like their emphysema and the damage that the smoking has caused. And then again, if there was unfortunately like an abnormality, we were able to show them that nodule or mass and make them understand it a little bit more, which also helps with our compliance rates for our return rate. Those patients almost kind of look forward to coming back and seeing if they have quit smoking, if their bronchitis looks a little bit better, and then if we are tracking a nodule, they like to be able to kind of see in person if that's grown or went away. And again, the radiologist is there in the room with us to go over those results.
Okay. All right. Thank you. Moving on. So now we're going to talk a little bit about your role as a lung navigator. So could you just elaborate a little bit on that, like your role and how it helps achieve your program goals?
Yeah, when we first started lung cancer screenings, Decatur Memorial started those back in 2013, but really didn't have a program until 16. So 13, they didn't have like strong eligibility criteria on there. And there was really no follow-up being done or management or tracking or anything like that. So they had decided that they wanted that kind of role to be owned by somebody. And I did go ahead and take that role over in 2016. And from beginning to end, really, we have the patients that inquire. My number is posted all throughout our town on different billboards and advertising things, and with some of the criteria. So I get calls occasionally throughout the day with just people wanting to get into the program, and they want to know how, and more questions. And then I talk with them to find out if they are eligible to enter the program, and then I help them if they need an order, get an appointment with the primary care if they don't have one, or try to get that shared decision making appointment made for them. And because some people just don't want to make all of those calls. So we assist in that, and then again, get the orders and help them get scheduled and set up. We have a couple of different facilities that we can image at, so we try to make what's best and convenient for them as far as time and location. And then the day of the scan, again, pre-COVID, we would go and get the patient and take them into one of our consultation areas and go over their results with them. Make sure they leave here with a game plan, whether that be, their screening time for next year, if everything looked great. And if it didn't look so great, then we get a hold of their ordering provider and either get their next step scheduled for them or a referral made to pulmonology or cardiology, because occasionally we'll see things that aren't really lung cancer related, but still are issues or concerns that need to be handled and navigated through. And all of that coordination is then communicated back to the ordering provider, whereas we like to help the ordering provider. We're not taking their patient away from them, and that communication is key for them to continue to know that their patient's medical history, but also that they know that they're being taken care of. That's been really big the last few months, with the offices being, overloaded and just not enough people to do all the jobs that are required. And then once the patient's gone, we make sure all that data is collected and submitted into Aspen Lung, which is then put into the ACR, and appropriate. We still mail out result letters both to the patient, and again that the ordering provider gets the results, and then reminder letters for further treatment and scans.
Okay, wonderful. Okay, and that probably leads right into our next slide, the use of technology. So I know you touched a little bit on that, but could you walk us through the technology that supports your screening workflow?
Yes. 2016 is when we took on Aspen Lung. We already used MRS breast, and this was made by MRS, so perfect transition for us to use, and very user-friendly, much better than trying to track everything on an Excel sheet. We were doing that, and once you get big enough, that's almost impossible to do, and just be able to keep up with everything, and just so timely to try to sort and all of that. So this system has been great with, our EMR we share with another organization, so our EMR does not talk to Aspen for us, even though that is a feature, and we did collaborate with another organization last year, and so it is in the future for us to have an EMR that talks with Aspen, but until then we do manual entry, and that does take a few minutes, but the good thing with Aspen Lung is it submits everything to the ACR for us. Before we were manual entry into both, so that took off a lot of time. We use Aspen Lung for all of our data entry, so then we can run our reports and find out at the end of the month, our numbers, our LVADing, how many people that we needed to follow, how many people we referred out to different specialists, and that we continue to track and follow. So that's been really helpful. And then we added MeVis, the Viality, for the CAD system, the computer assisted detection, for our radiologists to have an overread on. And they enjoy having that, and just a second kind of set of eyes, and they does some size comparison whenever we bring the patient back for abnormalities, and shows the differentials and all of that.
Yeah. And how the use of your technology, how do you think it has evolved as the program has grown?
Very much so. It's funny to even pull, like I keep all my reports, and even though I do have them all in Aspen, you always have to prepare for that day when the computers might all crash or whatever. So I keep all my paper reports that I run monthly in folders just to have, and it's awesome to be able to see my 2016 folder compared to like my 2019 folder, and just how overwhelming it would be if I didn't have a system to track all that, if I was still manually tracking. So whenever you go from averaging 20-some patients a month to now 120 to 130 patients a month, it's nice to be able to push a couple buttons once we've submitted all that data into Aspen, and all those reports are ran for us, so we don't have to do manual reporting out for who we need to track, who we need to follow, whose biopsy we need to, see that came back, and continue to track our abnormals and cancers.
Great. So you would definitely say the technology has made your life easier then.
Yeah.
Great. All right, let's go next slide. So now we want to cover the impacts of COVID-19 on your lung program. Okay. So according to the National Cancer Institute and the American Cancer Society, lung cancer is the #1 cause of cancer deaths in men and women. ACS estimates that there will be more than 225,000 new cases of lung cancer this year. Still, the COVID-19 pandemic is presenting obstacles in patients receiving diagnosis and treatments. So what I want to ask you, Jeri Ann, are what obstacles did your program face at the start of the pandemic?
All right. Our organization came out, and we shut down all screenings as of the week of March 16th. And we were down until the first week of May, which we were actually one of the earlier organizations to start back up, because we do have the benefit of having imaging centers that are off of our hospital campus. And we designated those kind of as our clean buildings. We had, of course, we have screening at every door, but we only allowed screening diagnoses to come into the imaging center. So they were no diagnostic tests, nobody that were symptomatic were allowed to have imaging there. So we really pushed that out for like our mammography and lung cancer screening, so the patients could feel more comfortable, not necessarily going on to hospital's campus. So we started that back the first week of May, and we were at the imaging centers only. And then it was probably end of June, beginning of July, where we felt confident enough that we had all the processes and policies in place here on campus that we could bring some of our screenings back, because of people that where they live, and they had other appointments here on our campus, that it was just a lot more convenient for them to be here. And we recognized that too. And as people got more familiar with COVID, they got more comfortable with knowing that we did have practices in place to try to keep our patients as safe as possible. So, but we did see a 6-week delay where we didn't do any screenings whatsoever, which backlogged us over 150 patients to get rescheduled. We did our best to not cancel those. We would always give them a rescheduled date, which meant at the very beginning, sometimes our patients were rescheduled a couple times because we didn't know what COVID was going to look like, what our delay was going to look like. So thankfully, most of my patients were very accommodating with that, and even kind of requested to be put out a little ways until they could get more information on what the pandemic was actually going to look like. We kept, thankfully, using Aspen Lung, we kept record of our patients that didn't get scanned in the appropriate, month that they should have been followed up. And for a while, we were sitting with about a 10% backlog, but when we did our last month numbers, we're only have about a 5% backlog of patients that still don't feel comfortable coming in and getting their screening.
Good deal. All right. So cancer doesn't wait for COVID, but it can be hard for patients to overcome with fear. Is that what your current practice is experiencing, would you say?
Yes, yeah, they get, and rightfully so. I think a lot of places are seeing it right now in the United States. It went from just being kind of in the media and on the news and not really knowing people to now there's not very many of us that don't know of someone that either had COVID or unfortunately has passed from COVID. And so, as you can imagine, a lot of our patients that are in our lung cancer screening program, because of their smoking history, have compromised lung volume. And so they were even more nervous to contract that. And so we were very, respectful and understanding of that for sure. But you also get to a point where some of our really high risk patients, you didn't want them to go with an underlying lung cancer for too long either, because as we all know, the sooner you catch that, their survival rate is a lot higher.
Perfect.
And then as far as like our program itself, since we shut down half of March and all of April and a little bit of May, our May, June, and July volumes were pretty high. But again, we had those imaging centers to utilize, and that was really nice for our organization to have.
Absolutely. So it's still great to return to your screening. Okay, let's see, next slide. So how did you locate the patients that you need to get back without any further delay?
Okay, we in Aspen Lung, there's several different reports that you can run. One of them being the patient overdue for follow-up, and we can run that, at the end of the month. We also generate reminder letters for their follow-up or annual appointments. So that was another way that we mail those out, and we would get response from our patients when they received their letter. And so that was another way of approaching them. And then, in all honesty, at the very end of the month too, I would just run my last year's May, June, July, and cross them off if they had come. If they hadn't, then go through and just manually called all of them and just tried to use our organizational's verbiage to try to help with the fear factor and get them back in, or at least get them rescheduled. For the most part, since I kind of manage my own schedule, I had made sure that people stayed on my schedule, but some of them still went through our main scheduling department and were dropped off that way. Mm-hmm. So that was the way I could go in and make sure all of my patients were either put back on the schedule, or I have documentation in my files that patient wants to wait until spring of 2021 or what have you.
Sure. Okay. Now, what would you say out of all those different type of communication, which one was most effective, or what have you found is most effective in communication with your patients? Communicating.
Honestly, because again, with having that radiology consultation services, a lot of them know me and my face, my voice, or whatever. So having them, and whenever I do my reminder letters, I have my stuff personalized through Aspen. It gives you the feature to personalize your letters. So my name and my number is in there. My patients have all of that. They leave here from their scan with next year's scan wrote on my business card, again with my name and my phone number, and they know to call if they have any issues. So sometimes just reaching out to them and kind of talking to them and explaining some of the processes that we had in place, and letting them know that we do understand the fear factor, and how some of the ways we went around trying to help with the safety of the patient. And that seemed to help a lot. And then you can just tell from having that conversation that there's going to be just some patients that they are still going to want to wait, and you can just feel that through their conversation. But again, I didn't want them dropped off completely. I would just say, hey, what do you think if I go ahead and put you on, in February, and I give you a call then, and we reevaluate how everything's going, and whatever. Some of my patients want to wait until the vaccine's out, or
sure.
So I think that's probably been the best way of doing it, is just printing off my report and giving them a phone call.
Okay, that's great. All right, useful technology in tracking patients. So let's look a little bit more closely at the role of technology in getting patients back. Can you share the different types of reports that you have found valuable?
Yeah, the overdue patient report will give you, everybody that you have submitted into Aspen, what the radiologist recommendation is. So that will let you know and you put the timeline, whether that be 1 month, 3 months, 6 months, or whatever. And then that report will let you know that they are overdue. They didn't have that done. And then you print that and you find out why. And then we document in there if there is a certain reason. Sometimes just because the radiologist recommended that, their ordering provider they know the patient, their medical history, so they might decide, hey, for my patient, yeah, the radiologist said this, but I'd feel more comfortable if we do this. Or they talk with their patient and they decide a different type of follow-up, and we just make sure we document all of that. So, and if there's any delay on what looks like a delay on our end is documented. And then again, I do the prior year patient report just because that is real time. I'm not really waiting for them to necessarily be considered overdue. That's a report I can run and know that they're supposed to be in, they're not scheduled, and go ahead and try to get them as scheduled as close to that year mark as possible.
Gotcha. Great. So it sounds like reports and reminders and notes in Aspen Lung have helped you kind of manage any sort of delays that you have.
Yes. Yep. And then, because that also, whenever we go to do our reminder letters, occasionally, when we look up prior imaging, that patient has, and especially because of COVID, they have been in here, unfortunately, like as an inpatient or an outpatient because they've had some issues with lung, or they've been COVID positive or whatever. So they've had imaging. So then that tells us to contact the patient, push that imaging, their follow-ups out, because they've had some additional diagnostic imaging in between their screenings.
Great. All right. So lung screening is a specialty given the nature of COVID that may have some unique findings due to positive status or permanent lung damage as a result of COVID. You using Aspen Lung to make sure that you have that you have the patient insight on COVID to understand the impacts of this disease.
All right. Again, when I was talking about the delay in treatment, we document, like, if the patient states, hey, I'd really rather wait till the spring when this, maybe blows over, again, they're all kind of guessing. And then some people want to wait for the vaccine, so we, again, document all that because we just want to be able to show on our end that we did try to get the patient back in and that was their choice. And that way, if an ordering provider calls me, they were like, hey, Jeri, I don't see this person scheduled. Why is that? Or why are they 4 months out later? And I'll just tell them, like, hey, I talked to them and this is what they told me, and, that kind of thing. And then it's just good to document that is the reason. And it wasn't because they just got dropped off the schedule and didn't give us a call back. Or and then the people that have been COVID-19 positive, we do capture that information, or if they have had additional imaging due to the COVID-19 virus, that we document all of that, and that's why they're now off schedule for their screenings. And then there is a section, unfortunately, in there whenever we go to run our reports that they've passed away. And I've had about 10 in my program so far that their death is considered a COVID-19 death.
Okay. And do you have any plans to reflect on the analysis of the data?
We don't have anything set in stone yet, but that's kind of why we've been a little bit proactive in using Aspen and putting tags on those people and in the history and all of that, because I have a feeling that is going to be something that some of the collaboratives and organizations that we're a part of, that we share some of our data and information with, I would not be surprised at all if that's not something that comes about in the future, like any delays in your days to diagnosis, or any, unfortunately, we could even see some staging changes. We might notice that we, unfortunately, instead of catching more stage 1, where we have more of a stage 2, stage 3, because we've went, several months between screenings or follow-up scans. And then it will be kind of interesting to see, whenever this is hopefully, gotten under control and all that, how many at the very end of all this we did lose, unfortunately, that were deceased because of COVID-19. So I see that becoming something that will be interesting information for the years to come.
Absolutely. And know that your program's probably definitely not, alone. Do you have any additional advice to others, kind of dealing with the same things?
I think the main thing, and that has been kind of nice, is my director and I are a part of a couple different collaborations where we get on and discuss monthly, like, how we're handling it, how they are, and try to, like, get best practices from each other and share some of our data. And it is kind of nice, like you said, to hear that we aren't alone. We're all kind of in the same boat whenever it comes to some of the issues that we're trying to face. And it's been neat to be able to hear how different practices have, tried to attempt to overcome some of the, if it's possible, some of the things that have been thrown our way because of the virus. But for the most part, just documentation is key, and that's why it's been really nice to have Aspen, for sure. I mean, I literally just type in their name and I have all their notes, and I can, there's an endless amount of notes that you can put in underneath your patient. So just keep that patient profile up to date.
Absolutely. Okay. Thank you.
So this is Erica joining again. I want to thank both Jeri and Lauren for leading us through this dialogue. We recognize that everyone is very busy and wanted to keep it brief, but I think Jeri's last comments really say it well. We're all in this together, and learning from each other is so important, and sharing what's working in real time. Now would be the opportunity for you to unmute yourself to ask Jeri or Lauren a question or type a question in the messaging. We have received a few in advance of this webinar. So maybe the first one for you, Jeri, if you could provide some additional commentary. With the rising numbers, the shutdown the first time surprised many people. Are you doing anything proactive, recognizing that the numbers are growing and the conditions of your local area may change? Are you learning anything from the first go round that you're applying now?
Yes, I think the biggest thing is we all decided from, again, mammography, lung cancer screening, colonoscopy, all of that. And I think you can even see a lot of that in the media news, and we're not the only organization that have decided this. Shutting down completely was not probably the best approach that everybody has decided after the fact, because like Lauren had said, there's a lot of, unfortunately, cancers that were missed and put off and treatment, and that was put on hold. And yeah, we were trying to be proactive and not or trying to contain the virus or whatever, but we were putting other health things on hold that didn't necessarily need to be. So this time around we are not shutting down completely. However, we've kept all of our cleaning policies and screening practices in place that we've came up with these last 8 months and practiced diligently to keep our patient population safe. And so I think it's because we feel more comfortable and confident in that since we are so far into this, even though we're kind of at the peak at it right now in our organization anyway, we feel comfortable bringing those people in and now feel like we have the verbiage and all of that to make our patients comfortable. But we are definitely not shutting down completely. That is the one thing we did learn from the very beginning that we're doing differently now that COVID has really kind of hit our organization.
Great. I have an additional question that came in specific to how you managed the increase in the volume during those summer months after you reopened. Any tips from that experience?
Yeah, we again are a little bit unique in our organization to where we do have imaging centers. So we ramped up and kind of relocated our staffing and all of that to where we could run both of our imaging centers full time along with the hospital scanners. And there were days where all of my imaging center techs, all they did was lung scan after lung scan after lung scan, but that was the only way we were going to get caught back up and then still be able to keep our main scanners here at the hospital for inpatients and other outpatients that weren't screenings, and our emergency scanners and all of that. So that was our biggest probably help in that area.
Great. Are there other questions? Did I hear someone unmute?
Oh, yeah, actually, I wanted to ask a question more, I guess, from the staff side. I know there's a lot you've done to make patients, I guess, feel more comfortable coming back in. How about your own staff and how have they done, especially knowing that, patients may be coming in COVID positive?
All right. Yes, we actually have daily huddles in our department going over the very beginning. I'm sure all of you guys experienced this too. PPE changes. We were in a 1 hour meeting and they changed 4 times in 1 hour. So the very beginning, it was very overwhelming. Thankfully, there has been a couple of changes here and there since midsummer, but we've stayed pretty much on par with our PPE, and we literally end our daily huddle every day with, are there any questions, concerns, especially with safety? And our technologists, our communication is key, is what we really learned with that. And that way they can ask any questions. We have our safety monitors on staff at all times, 24 hours a day, that we have open communication with if our technologists have any questions as far as that mask. We do mask fitting. give them the data, and we are pretty strict with our staff, our CT staff especially, because they are our main imagers for the COVID-19, is to keep their N95s on, and we screen heavily our patients, especially my screenings, because if they are asymptomatic, so they're not something that need to be like urgently done. So whenever I call my patients the day before and do reminder calls, and whenever I do that, I go ahead and go through the screening questions then. And so I know with, the night before that they qualified to enter the building, they still have to pass our screening entrance and get their temperatures taken and all of that to get into even our screening centers, the imaging centers. And so far, we've done pretty well with keeping our staff safe and them feeling comfortable. We've not really had any issues. And then, of course, that communication was definitely key in that aspect, and just letting them know that there's not one question that was considered silly, or we wanted them to feel safe. So if they had any questions, no matter what they were, to ask them.
Jeri Ann, we have one additional question, which is specific to if you could share a little bit more detail about how Aspen Lung helps you with the submission to ACR, and how that makes the process more efficient for you.
Yes. When we first started using Aspen, they didn't have it quite set up to submit to the ACR for us, the Lung Cancer Screening Registry. So I did a little bit of manual submission into Aspen and then ACR, and that took a lot of time. So we were ecstatic whenever they got that connection made for us. And it's a feature in Aspen where you export to the Lung Cancer Screening Registry, and it's literally one click to get to your list of all the patients that need to be exported. You pick your date range, the patients that you need to export, and another click to export them, and you log into the Lung Cancer Screening Registry and submit them, and within 24 hours they're submitted in, and it lets you know if there's any errors or anything like that, like if you didn't put if there's a typo in anything that you might have put in incorrectly data wise and the ACR doesn't accept it, but yeah, that's a very nice feature.
Well, if we have no additional questions from the webinar attendees, there is an email address here where you can email your questions either for Jeri Ann, or if you have a question specific to the Aspen Lung technology, we're happy to get that answered by our experts as well. So thank you, everyone. Thank you, Jeri Ann. Thank you, Lauren. Appreciate you sharing your experience. And I hope everyone stays safe.
Thank you.
Yeah.